In this episode of EHA Unplugged, we will revisit a spotlight talk from EHA 2024. Dr. Jurjen Versluis from the Erasmus Medical Center in Rotterdam discusses the need to use innovative clinical trial designs in the era of personalized medicine in hematology.
My name is Jurjen Versluis. I'm a hematologist at the Erasmus MC in Rotterdam, and I'm also highly involved in trial design and within HOVON, and related to this topic, do some research. So for those of you who are aware of clinical trial design, there are a couple of stages to consider in the clinical trial development. And the first part of trial development is the idea. Everything starts with an idea and a drug, an opportunity to investigate, do an experiment, and usually use a control. And when there is a design, you need to be aware of the effect size of your drug and discuss that with your statistician. And as a result of that, there usually comes a protocol, and eventually you'll start recruiting patients. And when you recruit patients, there might be room for interim analyses when you have the time and the equipment to do that. And at the end, you'll do a final analysis, which is usually set out at the beginning, at the design of a trial. And at final analysis, you execute everything you thought of when you designed the trial. This is quite a fixed and sometimes rigid process where there's no room for changes during the trial. And these are actually exactly those things that might be innovated, which I will talk about today. So why do we need to innovate trial designs? We are all aware, especially in hematology, of the era of personalized medicine. There are multiple drugs becoming available specific to subtypes of patients who have a target, a mutation, for instance, for whom those drugs are available. But in a clinical trial, it's usually difficult to enroll large subsets of patients when there's only a few patients who have that actual mutation. So in that era, we need to think of other approaches to clinical trial design. And also, since outcomes of our patients are getting so much better, studies take a long time to enroll patients. And as a result, we need to wait a long time for the final analysis, and studies become expensive because of that long follow-up time. So these are, I believe, reasons to innovate or think of innovation in clinical trial designs. And there's also, so I talked about the targeted treatments, which are also biomarker-driven approaches. And on the other hand, when talking about time and costs, we have the early endpoints, which is a different topic, I believe, but surrogate endpoints who might serve, for instance, for overall survival, which MRD is, for instance, being used. Those early endpoints might actually facilitate a sooner end of your trial, but that's a different topic to discuss, and I'm not going to focus on that today. There's also another method, which is more important, I believe, is early intervention for a very efficacious or a futile trial. And which is getting very hot in the last years is the use of external control data for your clinical trial, which I will also address. So when we talk about personalized medicine in clinical trial designs, there are three key types of trial design one should consider. And the first is the basket trial, which is a type of trial which usually enrolls multiple diseases, where there's one targeted intervention specific for usually a mutation, and that common target is investigated in such a trial. But such a trial could include solid oncology patients, but also hematology patients, and it's really a mixed bag of different types of diseases. On the other hand, we have also umbrella trials, which is usually for a single disease, but within that single disease, when there are multiple targeted interventions available, those targeted interventions are investigated in such a trial, and in these types of trials, there could even be a randomization. Both of these trials, basket trials and umbrella trials, are early phase trials, usually phase 1 or phase 2 clinical trials, mostly phase 2 clinical trials. During the COVID-19 pandemic, platform trials have become very popular, where there's a continuously running standard of care arm, where there are always patients receiving that standard of care. And when they are becoming interventional treatments, alternative treatments available, patients are at that point could be randomized to that intervention. And there are in a platform trial usually a couple of interim analyses where at that time an intervention is reassessed, and when there's a clear sign of efficacy or futility, that drug, that intervention is dropped. These trials are attractive because if you design it properly, the standard of care arm could run for multiple years, and when available, different types of drugs or experiments could be added during that trial. And this serves as a sort of master protocol which you could always rely on when adding the new treatments. These types of trials are a bit more difficult to design when you talk to your statistician, but I really encourage you, if you have these type of treatments within your disease type, to consider these trials, because the standard of continuously running standard of care arm is very attractive. The next thing I want to address is, like I mentioned, the early intervention for a very efficacious or futile trial. No one wants to do a trial who at the end is either very negative or very positive, and always comes the question if you could have seen that coming. And these type of trials are called adaptive trial designs. And the example I want to highlight here is based on HOVON data, and this is an example in multiple myeloma, where the trial randomized two treatment arms, a control treatment arm versus an intervention arm. And at the design of the study, it was estimated that 668 patients needed to be enrolled. And at final analysis, the result was quite disappointing, because there was no difference between the experimental and the control arm. We questioned whether we could have seen this coming, and whether, if we could introduce interim analyses, maybe have changed the course in this trial retrospectively. I will show you two methods now. The first one is the group sequential design, which actually allows you to introduce interim analyses, and at interim analysis you could decide based on the boundaries I will show you whether a trial should be continued. And in this example, we introduced two interim analyses. The first interim analysis was when there were still patients being enrolled, and at the second interim analysis we observed that all patients were already included, but at 2/3 of events we had still some follow-up time to monitor. And if you, for instance, could consider at the first interim analysis to stop the trial, you would actually save patients from a potential futile or efficacious treatment. And at the second interim analysis, you could primarily save follow-up time. So if we, again, retrospectively apply this to this HOVON multiple myeloma trial, you'll see interim analysis 1, interim analysis 2, we were not able to firmly say that this trial was going to be a negative trial and we should stop the trial. And a key concept of the group sequential design is that when more data are being observed, the bounds of efficacy and futility are getting closer. In other words, your estimate of the data is getting more precise, and therefore you're more precisely to say if your trial is going to be still promising or whether your trial is going to be a negative trial. At the final analysis, we did not observe any difference. Another approach we introduced here is a sample size re-estimation design. And what is really attractive here is that when you are conducting your trial, you're reassessing your power. And the power is important when designing a trial, because you want to be sure, you want to have some probability that your trial is actually going to be showing a real effect. And when the power is very high, above 90% usually, that's a very favorable result, and that's a scenario where you could consider stopping your trial for efficacy. On the other hand, when your trial is at below 30%, which is a probability of 30% that you're going to observe a real difference, that's considered a futile trial, and then usually a trial is stopped. And the promising zone is the interesting zone where, and that's usually set at between 30 to 90%, where the sample size is being re-estimated. So during your trial, you have the feeling that this trial might have some interest, but at that time, you're not sure, definitely not sure whether your trial is going to show that eventually. And then you could enroll additional patients. You could re-estimate your sample size. And in this scenario, that could have been resulted in 1/3 of additional patients in your trial. When we calculated the conditional power, and we did that at the second interim analysis, we found that this study actually had 17% conditional power, meaning that this trial was very unlikely to show efficacy and actually was futile. And therefore, in this scenario, retrospectively again, we could have decided that this trial should have stopped, which in this case, because it was after already 2/3 of events, meaning the trial was already completed for inclusion, but it could have saved follow-up time. These are the adaptive trial designs. We also recently used a Bayesian type of analysis to investigate whether we could improve decision-making in a clinical trial by using a Bayesian methodology. The Bayesian methodology has 3 key concepts, consisting of a prior, which is the belief you have before you start on a trial. And this is, for instance, a complete remission rate you expect for a leukemia patient, which is usually after induction treatment about 80%, 85%. And when you observe additional data, in a very positive trial, you might observe a very high remission rate, for instance. Updated likelihood, your guess, what you observe is better. So your updated belief is in between. That's the posterior. And that's a key concept of Bayesian analysis, which I will show you how that performed in our AML analysis. And this is again maybe a disappointing HOVON example, but it helps to use these examples to investigate what could have changed. And if we looked in this trial, this was the HOVON 132 trial, we randomized almost 800 patients between a control treatment and experimental treatment, and we observed clearly no difference. However, at the design of the study, the expected hazard ratio for benefit was 0.76, while the observed hazard ratio was 0.99. And again, we questioned, could we have seen this coming when we introduced interim analyses? So that's what we did. We introduced 4 interim analyses, and when using the group sequential design, we actually observed that at the 3rd interim analysis, the futility bound was crossed. So at the 3rd interim analysis, after 450 patients, we, using this type of adaptive designs, might have considered to stop the trial because efficacy was never going to be shown. However, if we use a Bayesian analysis, and one of the strengths of Bayesian analysis is that you're also able to reinforce your control arm by adding additional patients, and we used the previous HOVON trial also including AML patients, we actually showed that using that Bayesian approach, after the first interim analysis, so after 150 patients, there was a 1.2% probability of being successful, of being able to show that 0.76 expected hazard ratio we had at the beginning of the trial. So using a Bayesian analysis and reinforcing your control arm, we were able to show that that trial was already very early going to be a negative trial. So these are examples of methods to introduce interim analyses which might really help you during a trial to be sure that you're able to demonstrate the beliefs you had when you designed the trial. External control data, I mentioned that at the beginning, are increasingly being used. And we also investigated, thinking of the Bayesian analysis where you're able to reinforce your control arm, if you are able to use external control data, whether that helps to compare, to reinforce your control arm. But the question is, are external control data really helpful? Are those really comparable to your clinical trial? So we again used an approach where we took the control arm of a HOVON trial and we sought for external control data to reinforce the control arm. And we identified 2 potential alternative data sources. The first is the Harmony Alliance data source, and the other is a truly real-world data set of patients gathered in the Netherlands by the Dutch Cancer Society, who also received the same intensive AML induction treatment. And we questioned whether the control patients of the clinical trial were actually similar to the external real-world control data arms. And when we looked for baseline characteristics, we clearly, and that's not surprising, observed differences. Missing data was much more common in the real-world data source, but also within the Harmony data source. And when we performed the matching method, we observed, this is overall survival, that outcome for the HOVON control arm was actually similar compared to the Harmony data. But I have to acknowledge that the Harmony data is basically a data set who consists of the majority of clinical trial patients. And in this case, in our analysis, we found that about 60 to 70% were actually enrolled in a clinical trial. However, the real-world data from the Dutch Cancer Society, those patients clearly performed worse, 10% worse survival, overall survival at 2 years when compared to HOVON controls. And we really believe that this is due to various reasons, but for instance, the missing performance status, how fit is your patient, and is that really a patient who could also be included in a clinical trial? Is it comorbidity data, all types of data that are not available in a real-world data set. So we are really hesitant to firmly say that real-world data could actually supplement the data in a clinical trial at this stage. So I hope to have shown you that innovative trial design is the future. And with the personalized medicine becoming available now, we need to adapt our trials according to the needs, to the accelerating needs within the clinical trial development to deliver the right drug for the right patient at the right time. Adaptive designs I've shown you and could help you for potential and early trial intervention. External data might reinforce your control arm and important in that perspective, but you need to define and identify the right and the proper external control data set. And with all this, and especially if you want to adapt your trial during the conduct of your trial, you need a solid trial infrastructure where you have immediate data available and who can support the complex trial that you might design. And with that, I would like to conclude. Thank you.